Welcome to AETCM, the Emergency Medicine channel. Today we are discussing a case about a female patient who came to our ER with right side shoulder pain. So, shall we start? 55-year-old female came to our ER with alleged history of slip and fall and complaint of pain on her right shoulder. On initial assessment, patient was conscious and oriented, obeying to my commands. Airway is patent. There is no pooling of secretion, no stridor or hoarseness, there is no oral bleeding, and C-spine, there is no pain or tenderness. Breathing, respiratory rate is 18, saturation is 99% room air, and bilaterally air internally equal, there is no added sounds. Circulation part, heart rate is 86 per minute, BP 150/84 mmHg, CRT less than 3 seconds, and all peripheral pulsation are felt equally and bilaterally. Disability, GCS is 15/15, pupil bilateral equally reactive, and disability part restriction of range of movement of right shoulder with pain score 8/10. That time we give injection PCM 1 gram IV stat. And exposure part temperature was normal.
Actually in ATLS, when we say disability or deformities has to be mentioned there, long bone fractures, because we are usually this is trauma. We are saying about trauma, right? So trauma, long bone fracture induced deformities, we need to say in D. Because why? Because we are suspecting internal hemorrhages. So patient is having a deformed upper limb, humerus. Basically, we are saying that there is a shaft of humerus fracture. Patient may have a vascular injury there. Patient is having a deformity in lower leg. Long bone fracture, suspecting vascular injury. The idea is to suspect vascular injury, not long bone fractures. Okay, we are not saying it's not important. The thing is, we should not miss vascular injuries. So here, disability or deformity, usually we ask the patient just to move their extremities, move all 10 fingers and all 10 toes. Because in disability in primary survey, we are ruling out spinal cord injury. We are not ruling out individual limb assessment. Individual limb assessment comes in secondary survey, musculoskeletal examination. Okay, because these are known life-threatening conditions. So in primary survey, our idea is examining and identifying life-threatening conditions only. Whole body examination is next part. Here you ask the patient told I have pain over here, that and all is fine, but when we present the case, disability is basically spinal cord injuries. Okay, fine. PCM was given. Then
Ambulatory history, patient has, there is no known comorbidities. Patient had an alleged history of slip and fall, and she fell down with outstretched hand, following which she had pain over right shoulder and restriction of the range of movements of right shoulder. There is no history of head injury, no LOC, no history of vomiting or ENT bleed or seizures. Head to toe examination, there is no facial injury. Neck examination, there is no C-spine tenderness. And shoulder examination, inspection, first we expose the both shoulder, and right shoulder is lower position when compared to left shoulder. And attitude of the right upper limb is abducted and externally rotated and supported with the other hand. There is no laceration or abrasion on the right shoulder, and there is loss of shoulder contour is there.
good.
Inspection part. Palpation, there is tenderness over the right shoulder, and the head of the humerus palpated the infraclavicular region.
Infraclavicular region. Infraclavicular region is here. Mostly what we get is just anterior lateral displacement is what we get. It's just below the coracoid process we get. But patients can also have it in the axillary region, that is subglenoid region. So subglenoid region is much more difficult to detect because there is significant displacement from the shoulder joint. But if you palpate the axillary part by putting your hand inside, you will definitely feel a bony prominence there. Yeah, but infraclavicular is actually very medial, right?
Subcoracoid region. And movements part, all movements of shoulder joint are restricted. Then we examine the neurovascular examination. Distal pulses are palpable.
When you say restricted, that restriction's reason also we need to mention, that is pain. The patient cannot do any shoulder movements due to extreme pain.
Neurovascular examination, distal pulse, brachial artery, radial artery, ulnar artery are palpable. There is no loss of...
Are we suspecting any radial artery or ulnar artery injury in a shoulder dislocation? We don't, right? Ulnar artery and radial artery doesn't have any relation to shoulder as such. It comes below shoulder, isn't it? Which artery is likely, if at all involvement is there, which artery can be involved?
Axillary artery.
Axillary region. So axillary artery is the possibility there. Okay.
Nerve examination. Normally there is a supply by axillary nerve. So we check the sensation over the bad side. There is no regimental bad palsy seen for axillary nerve.
Axillary nerve, which area it supplies?
The deltoid lateral to
teres minor and deltoid. But we can't ask the patient to examine deltoid. Patient can't move the shoulder. Right? So there is no point in muscular examination.
No,
what we look for is sensations. So where is the sensatory part of axillary nerve supply?
At the lateral side of the
shoulder. Basically this area. This is the axillary supply. So here you can ask for hyposensitization. So patient says that they are having paresthesias or decreased sensations, you can suspect axillary nerve injury. No, you have axillary nerve injury. Patient is telling, I am having decreased sensations there. What will you do?
First we stabilize the...
Will be suspecting in nerve injury? If
the patient is telling, I am having decreased sensation, I don't really understand, it is significantly low in comparison to my opposite shoulder. What will you do?
First to stabilize the shoulder. Any further movement will...
Okay, so you will not manipulate. Then do what? Call ortho for internal reduction. Axillary nerve injuries are fine in anterior dislocations. Most of the patients will have some amount of axillary nerve involvement that need not be taken into account for reduction. We can reduce patients with some axillary nerve hyposensitizations. That is okay. Usually, due to the traction of humeral head that is pulled down, some amount of axillary inflammation will be there, but that is usually resolved once the dislocation is reduced. So, axillary nerve injury is not a real contraindication for external reduction. External reduction we can do, but when should you suspect or when you should not do external reduction? Axillary nerve injury secondary to what condition you should not do external reduction?
Fracture.
Surgical neck of humerus fracture. Because surgical neck is where axillary nerve is actually winding around. So when there is a surgical neck of humerus fracture, the injury to the nerve can be due to the fracture site, not dislocation. In that case, if you try to reduce the fracture site, it can cause significant displacement between the head and the shaft, worsening neurological prognosis for the patient. In that condition, you should not do. So, if you get an axillary nerve injury, that is actually an indication to go ahead and do a X-ray, at least minimum X-ray, and look for surgical neck of humerus fracture. That is one thing that we need to look into.
Then we go forward with X-ray shoulder, right shoulder. Epilateral and scapular YV is advised. Epilateral was taken. Scapular YV patient not able to take due to the pain.
Why? YV requires patient to hyperextend the arm. Patient is already having restricted movement. Patient cannot do a Y section as such. So, actual Y requires patient to completely abduct the arm and external rotate, and that is very difficult. But we can take Y view just by putting the X-ray behind. We just want to see whether the head of humerus is displaced away from glenoid or not. That is the only thing we want. We really don't want it to be displaced down. We need to show there is a displacement away from glenoid cavity to say that we are suspecting a shoulder dislocation. Now, let's come into that. When a patient presents with the shoulder pain, patient is telling, I had a slip and fall. After slip and fall, I can't do anything with my shoulder. I am having severe pain and I can't move this shoulder. You do the examination. No? Here itself you did the examination, you identify there is a shoulder dislocation. You are telling there is absence of contour is there, head of humerus is displaced downwards is there. Patient is also having this thing, restriction of movements due to pain. So you are suspecting shoulder dislocation. What is the first thing you need to ask the patient?
Patient able to touch the opposite
No,
shoulder.
patient will never be able. Patient is having no shoulder movements, no restricted shoulder movements. Why you should ask that? There is no point. What is the question? Is this the first time or do you have previous history? That is the first question, because if it is the first time, we are going to face a bit more difficulty in reduction. If it is multiple times, the patient itself will tell, this thing usually happens, we can reduce it. Because at that point, our question is, anyhow, we have to do reduction. Question is a closed reduction be successful for this patient or not? That is our goal, is that, isn't it? Success of reduction. So success of reduction depends upon previous complications or non-complications. So patient tells, previously I had this, but it wasn't able to be reduced. I had to be taken to OT to reduce, or open reduction was done. Then there is no point in trying that. The patient will not reduce. There is no point. We can call ortho, plan admission, conservative manage the patient with the pain killers and immobilize the limb. That's all we can do. There is no point in doing closed reduction. But patient is telling, usually closed reduction can be done. Usually doctors, when they press itself, it will fall. It gives us much more confidence that this is reversible. And then we can ask one more question. Now, reduction of a dislocation is always painful. So if patient has chronic history, we can ask them what you are taken for last reduction. Certain patients, if it is very common, they will not even require sedation. Patient will be fine with time, over time they know to reduce the joint. What is the major difficulty we will face when we try to reduce a shoulder dislocation? Usually shoulder dislocation is not very easy, no? Like, it's easy once we got the rhythm and all, but there will be some resistance from patient side, no? We will find it difficult to put it back. Why?
Due to pain.
Due to muscle spasm.
Spasm.
Due to muscle spasm. So muscle spasm is the issue we are dealing with there. So muscle spasm, as soon it decreases, it will be much more easier to do it. That is why in the first time it is very difficult, because patient's muscles are not used to this. More times there will be much more lenient to manipulations. Similarly, sedation and all is more required in first time because we need the muscles to be relaxed. Okay, but as multiple times happens, over time with the adequate pain relief itself, patient will be allowing us to manipulate the arm. So, as emergency, procedure sedation is one of the things we have to do for shoulder dislocation. And shoulder dislocation is a condition which very unlikely will require IP admission. Patients can be reduced and discharged. Then our drug usage should also be short-acting drugs. Because when we discharge the patient, we can't discharge a patient who is not fully awake from a sedation. Okay, so better is not to use procedure sedation. For that, this history is important. Okay, what are the other risk factors for closed reduction failure or complications of closed reduction? First episode we told. First episode is a risk factor. Then elderly. Shoulder dislocation is predominantly a male presentation. More than 2/3 of shoulder dislocations are in males. In that also, young age group, less than 30 years is the most common age group in which you get more than 2/3 of shoulder dislocations. Okay, so more the age, much more complications we are going to face. So first episode, elderly age, and any major mechanism of injury. Like for example, this patient slipped and fell. We are not expecting a high velocity injury or high forceful injury. These conditions are fine. But if patient had a high mechanism of injury was significant, or a patient fell from a height, so in those conditions we will be facing a bit more resistance for close reduction. So mechanism of injury. These are the things that we look into to see whether there is a complication arising. So if we are expecting an injury that can cause fracture, then a pre-reduction X-ray is very important, because we need to take a X-ray and show that there is no fractures associated, showing that we can go ahead with reduction. X-ray is usually taken to prove there is no fracture rather than to prove there is dislocation. Dislocation is usually a clinical diagnosis. Post-reduction X-ray is required because we want to prove that we have correctly reduced the shoulder joint. So patient gives multiple episodes of previous reduction and very simple, minute force caused the reduction, dislocation. We really don't want to push for X-ray if patient is having significant pain or lack of time, and like ER is busy, you can't shift, or X-ray takes more time. You can go for reduction. Make sure there is no complication factors like increased age, first episode, and possibility of high grade mechanism of injury causing possibility of fractures. These things to be ruled out. Okay. Now, what are the types of shoulder dislocation?
Anterior shoulder dislocation, posterior and inferior shoulder.
Anterior, posterior, inferior. Now, why shoulder dislocation? One of the most common dislocation in human body is the shoulder. Why is that?
Anteriorly, there is no support by muscles, so it's common to dislocate.
Yeah, glenoid labrum is there, no? Because of decreased surface. Glenoid cavity and humeral head is very minimally on touch, means it's opposed very minimally. It's not fully covered like our hip joint. Because of that, the main stability is given by the ligaments and musculature rather than the joint face as such. That's why it is getting much more prone for displacement. So displacements usually will be in the opposite direction of force. So patient on anterior force can develop posterior dislocation. Posterior force can develop anterior dislocation. If they are falling from a height and they are catching on to something, there will be external rotation and abduction. So it can get inferiorly because it's being pulled up. So inferior dislocation. Inferior dislocation is very rare. It's very rare means very less than 1%. 95 to 97% is anterior dislocation, and posterior is also very unlikely. Usually patients will say they either slip and fell on an outstretched arm, which forces the humerus to roll out of glenoid cavity. Usually it is anterior in position. So as he told, there will be loss of contour, there will be prominence of coracoid process will be much more prominent, or acromion process will be prominent rather than the shoulder as such. There can be some desensitization of the skin over the deltoid, severe restriction of movement, shoulder movements due to pain. Now, patient's arm can be either externally rotated and abducted, or it can be internally rotated and adducted. Usually we see external rotation and abduction in anterior dislocation. Humeral head will be here, hand will be externally rotated and abducted. In posterior dislocation, usually humerus, means head of humerus goes behind the glenoid cavity. So it is usually internally rotated and adducted as such. But patients can present with either way. Usually this is what we see. You will examine for any fractures as such, and you are taking X-ray. So you take X-ray AP view, YHS view. These are the two things you will do. When you take X-ray, what are the things you will look for? on a surgical neck fracture, you will look for position of humeral head. Is it subcoracoid, subglenoid, or posterior dislocation? So, in case of anterior dislocation, it's very easy. You can clearly see humeral head moving away from glenoid cavity. It's not much doubts will be there. But what about posterior dislocation? Posterior dislocation, it is actually behind the glenoid cavity. So X-ray, it will not show an empty socket. This thing, head of humerus usually will be at the position of shoulder joint only, but it is posterior to it. So what you can look for is internal rotator, no? So normally we have the tuberosities, greater and lesser tuberosity, that is on the lateral part. That won't be there. The humerus will be like much more smoother and rounder. Usually when we see the greater and lesser tuberosity, that will be absent because of internally rotated. That is one thing in posterior dislocation, because posterior dislocation is very difficult to miss, very easy to miss. Anterior is very difficult to miss. You will usually bring it, but posterior, since humeral head is in place, just posterior but in place, you can miss that. Joint space is normal, so that you can look into. So you have taken X-ray. Any other deformities you can see in X-ray? Any
fracture or
Hill-Sachs deformities and
deformity.
Bangford deformities are there, no? So basically these are not contraindication for close reduction. Hill-Sachs deformity just means that the head of humerus has some compressions over the cortical surface, usually caused by the glenoid labrum. Bancroft deformities are due to either avulsion fractures of some bone fragments, or it can be due to cartilaginous injury. Cartilage anyhow you will not see. Avulsed bone fragments, even if it is there, unless greater tuberosity fracture is there, we can reduce. So surgical neck fracture or greater tuberosity fracture, we can reduce. We can go for close reduction. There is no problem in that. Only thing is vascular injury should be ruled out. Okay. Now, X-rays you are done. What is the next step?
X-ray shows anterior dislocation of shoulder. Then we plan for reduction of the shoulder. So first we give procedural sedation to analgesic and anesthetic effect. Here we give injection fentanyl 100 microgram IV stat we give, and along with injection midazolam 2 milligram also we give.
Okay, so the whole point of giving procedure sedation is, as we have already told, muscle relaxation. Okay, so when you get this case, it's not necessary that you need to give procedure sedation for each and every case. You can decide on case-to-case basis. The best thing is not to give procedure sedation, because procedure sedation patient will take some amount of time for coming out of procedure sedation. That much time we have to observe the patient's vitals and heart rate, saturation, because when we sedate the patient, there is a possibility of drug reactions, there is a possibility of central nervous depression, there is a possibility of tongue fall causing airway obstruction, causing desaturation, there is a possibility of hypotension, there is a possibility of cardiac failure. So there are multiple probabilities are there. It's not always, it's not like everywhere it will occur or risk factors are there, but these are possible outcomes that can be avoided if you don't go for procedure sedation. What else can be done? Actually, in chronic history patients, you don't have to do anything other than analgesic. But you can do one more thing. You can take lignocaine, around 15 to 20 cc of lignocaine, 2% lignocaine, which is commonly available. You can palpate your humeral head. So you have the acromion process, you have the humeral head. So you can palpate that, you will know that humeral head position. Here, there is no humeral head. That is the depression. You can inject directly into that area. You can inject directly around 15 to 20 cc of lignocaine and wait for 15 to 20 minutes. You wait for that, patient's area, that joint area will get anesthetized and muscle relaxation will occur. But patient will be fine. Patient can help you for reduction also. Pain sensations will be dulled. It will not be going away, but it will be dulled. We can go for this for multiple history patients, not first time patient. First time patient it will be much more difficult because patient will be very apprehensive and anxious and all. Okay, so procedural sedation is anyhow a big topic, so that will take next day. So how did you reduce this patient?
Here we use coaches methods we use. That is, we have already elbow 90 flexion, then we apply a traction, external rotation, then adduction and internal rotation. During the external rotation, we feel a click sound is the shoulder.
Any other methods are there?
Then there is Hippocrates and modified Hippocrates method. There we use cloth for traction or by applying the armpit. Then we one man apply or traction on the dislocated hand.
So basically, all our procedures is basically aimed at two things. One, pull the humerus from a elevated position down so that it can enter into glenoid cavity. That is your traction counter traction methods. You are pulling the humerus and pulling the body in an opposite side and trying to nudge the humeral head under the labrum. That is one method. Second method, whenever patient has anterior or posterior dislocation, your hand is at a fixed position. It's either externally rotated and abducted or internally rotated and adducted. That is because of certain muscle groups pulling on humerus. So you nudge the humerus out of that muscle's pull so that counter action of the muscles will happen and it will go inside. So as you told, we have Kocher's method and we have Stinson's method and we have modified Hippocrates methods. So there are a lot of methods. One of the easiest things we can do for a very cooperative patient, therefore this patient has to be a bit cooperative with us, is just ask the patient to sit in whichever position the patient's hand is, sit and move the hand in the same position patient hand is present. That is, patient is having abduction and external rotated hand. We fix the hand to the chest wall, keep it fixed and slowly external rotate the hand to the maximum possible. We are external rotated hand, we will externally rotate only. We won't internal rotate. Going against will cause more muscle spasm. So we will rotate it to the side wherever it is there. And as we are rotating it, we will palpate the shoulder joint and see whether the clicking is happening. So in this method, we can see that it can go up to 90 degrees or something. It can go up to a position. In this position, maximum externally rotated position, if patient is not getting reduced, now we have to exert traction. So what to do is we can elevate this limb to overhead position. Basically, from external rotated position, we are making it 90 degrees and then to overhead. So when it is in overhead, basically it is coming out of the anterior position and nudging it in. Now, whenever we explain these procedures in words, it's very difficult to identify because we can't see. When we see, then only it is easy. There are different videos available. We can look into that. But basically, either we give a traction, counter traction methods, or we always rotate, keep rotating in the affected area, affected direction till the humerus goes inside. So in posterior dislocation, it is adduction and internal rotation. We keep internal rotating the arm to the maximum. If it is external rotated, we keep external rotating the arm to the maximum. Whichever arm position, we keep rotating the maximum. So you successfully reduce the patient. How will you assess whether it's reduced?
We take a check X-ray.
That is true, but to shift the patient to X-ray, how will you keep the arm?
Able to ask the patient to touch the opposite shoulder.
Easiest method is increase in shoulder movements. Normally, if it is fully reduced, patient should be able to touch the shoulder. Patient might have pain. That is fine. but patient should be at least able to touch the opposite shoulder. That is one thing. Increase in shoulder movements, acute reduction in pain. So, but pain we may not be able to assess if you are sedating the patient. So, increase in shoulder movements we can look for. Then we will shift the patient for check X-ray and make sure the reduction is done. Then how will you discharge the patient? Before the discharging itself, you check the rotation of the shoulder. So, shoulder movements have increased. How will you stabilize this arm?
Immobilizer we use for
So
2
we have
weeks.
to use an immobilizer. And what is the position in which you will keep the arm?
Abducted and
Abducted, internally or externally rotated, both are fine. There is no clear method to do that, but abduction should be kept. Shoulder should be abducted so that there is no much gravity effect on shoulder, and forearm should be semi-flushed position so that gravity action will be minimal, and give a immobilizer. Check for X-ray. X-ray is done. X-ray there is full reduction, and reduction is properly achieved. Patient is also clinically fine. How will you dispose this patient?
by giving painkillers or
No, so you have to give him some painkillers. What are the options that you have?
paracetamol.
Ideally, NSAIDs,
NSAIDs.
right? So we want to minimize inflammation. So ideally, NSAIDs, if no contraindication, like renal failure,
liver failure.
bronchospasm and asthma history and renal failure are the main things we will suspect. Okay, so NSAIDs we can give. If not possible, we can give paracetamol. Then we have non-opioid alternatives like tramadol is there, Ultracet is there. Ultracet is a combination drug, right? Paracetamol and tramadol combination drugs are there. But we can give according to the pain sensation of the patient. So we need to ask the patient how his or her pain sensation is. Certain patients will be much more tolerable to pain. They will not require much analgesic, but certain patients will be not tolerant. Then you have to give adequate pain relief. So that is individualized. We should give individualized prescription for pain relief. What else? Always ask the patient to keep the arm in adducted and rotated position for 3 weeks. 3 weeks complete immobilization is what we ask them to do, and in 5 to 7 days they can review in orthopedics OP for further management. But 3 weeks of immobilization is there. In case of immobilization, we should also ask the patient to do normal small shoulder movements, that is anteroposterior movement and some amount of adduction abduction movement. But forearm should not be externally or internally rotated much. It should be kept in normal position. But anteroposterior movement and some amount of 10-degree abduction adduction should be done, or else shoulder will, the muscles will become stiff and patient will have difficulties in rehabilitation. Okay, so we asked them to review in ortho. Now, same patient came, you assessed. When will you call ortho? What is the indications for an emergency physician to call orthopedics rather than do a close reduction?
After 2 times failure is the
No. After you do close reduction, it fails, of course, you need to call them for open reduction. Other than that,
Head of humerus fracture.
surgical head of humerus fracture is there. We should call orthopedics. We should not manipulate that, because as we told, it increases displacement between proximal head and shaft. Vessels and nerve can get entrapped between bone fragments. Then
Nerve and vessel injuries.
in that, the problem is axillary nerve injury should not be that much taken into consideration, because axillary nerve, many of the conditions patients would suspect or say they are having some amount of sensation loss over the shoulder area. That we say it's an axillary nerve injury. It can be axillary nerve injury, or it can be due to the traction injury also. Usually patients improve out of it. So axillary nerve injury, unless patient has this significant muscle weakness, we don't have to don't do close reduction for just sensory loss of axillary nerve. The thing is, motor loss of axillary nerve cannot be assessed unless we reduce the joint. So accessory nerve is okay. But any other brachial plexus injuries are there, we should suspect underlying fracture and should not interfere in it. Okay, what else? If the head of humerus has multiple, more than 25 to 30% of injuries, that is our Hill-Sachs malformation and Manford malformation we told. If the total malformations or greater tuberosity fracture, all these things are there, more than 25% of injuries are there, significant injury that you think is there, you should not interfere, because even if you interfere, it can cause displacement of bony fragments, causing opening to realign the bony fragments, or else movements will be again restricted only. So on X-ray, any major visible deformities are there, you should call ortho. Surgical neck fracture, you should definitely call. Vascular injury, you should call. Accessory nerve, we can try, there is no problem in trying. Now, what other patients you should not try? Patient presents with shoulder dislocation. What is one condition in which you hear it, you are like, okay, fine, call ortho? Age of the dislocation. If dislocation has already happened more than 5 to 7 days ago, do not try to reduce it. And the failure of reduction is very high. So more the age of dislocation, less the chance of close reduction will be. Then we can directly call ortho as such. Anything else is there?